Good evening to everyone and welcome to today's wonderful evening with Dr. Murali Bharadwaz. So we are in the journey of social and preventive medicine. We finished the initial 900 points out of 3,600 points. 25% of the game is over. So by the time we master these 3,600 points, that is a total revision time of about 35 hours for the first reading. You will end up with about 500 to 600 points for the last moment revision before 30 days before the next NEETPG. And another 1,500 points you need to do at least one more revision during the course of time. So that's the whole plan with which we'll start. Very good to see 3 online classmates. And can you please check whether the voice is loud and clear online? Yeah. So now, pneumonia. How do we grade pneumonia? Acute respiratory infections is one of the very interesting issue for the examiner. So for the severe pneumonia, what is the drug of choice? Benzyl penicillin is the drug of choice. And overall, if I say for pneumonia, not severe, what is the drug of choice? Cotrimoxazole, which is trimethoprim plus sulfamethoxazole, is considered to be the drug of choice. Now, the pneumonia, acute respiratory infection is divided into no pneumonia, pneumonia, and severe pneumonia, depending upon the symptoms of the patient. So one of the common questions asked in the entrance is, the child's clinical features are being given to you, and you are asked to identify whether it is no pneumonia, pneumonia, or severe pneumonia. So if there is only cough and cold, and you examine no chest indrawing, no fast breathing, and no antibiotic, in that case, you call it as no pneumonia. No fast breathing, no chest indrawing, only cough or cold. There, no antibiotics are needed. And only if the cough is persisting more than 30 days, then it requires assessment. So that is the story of no pneumonia. Then pneumonia, but not severe. When do you call? If there is no chest indrawing, then it is not severe. Only what is present is fast breathing. And at home, you will advise to be managed. You give antibiotics, and drug of choice in that scenario is cotrimoxazole. And after 2 days, you ask the mother to bring the child for reassessment. So this is one of the favorite questions of the examiner. Then, when do you call fast breathing? What is the respiratory rate cutoff? You know how to examine respiratory rate? A lot of times they don't teach in medical college. You're checking the watch, then you're placing your palm on the abdomen. 1, 2, 3, you're calculating. So 0 to 2 months respiratory rate more than 60 per minute, 2 to 12 months respiratory rate more than 50, and 5 months to 12 years respiratory rate more than 40, then you call fast breathing. Fast breathing means only severe, only pneumonia. Associated with chest indrawing means severe pneumonia. That's the point you need to appreciate. So in severe pneumonia, what are the clinical signs? Chest indrawing, nasal flaring, grunting, and cyanosis. And how do you manage? You give the first dose of referral antibiotic, ampicillin plus gentamicin, because you are working in a primary health center, etc. Severe pneumonia you can't manage unless you have got a setup for pediatric intensive care. You refer urgently to hospital, And antibiotic ampicillin plus gentamicin need to be changed if there is no improvement after first 48 hours. That's the point you need to appreciate. Now, what are the drugs which are administered for severe pneumonia? Very good to see Drive Medicine and many more online classmates. Very good. Benzyl penicillin or ampicillin or chloramphenicol is the drug of choice for the first 48 hours. Then procaine penicillin or ampicillin or chloramphenicol for the next 3 days. Once more, you should know what is benzyl penicillin, what is procaine penicillin, what are the differences, which is given orally, which is given IM, which should not be given IV. All these things we will discuss in pharmacology. All right? Now, what are the signs of very severe pneumonia? The next category. If there are convulsions, abnormally sleepy, difficult to awake, if there is a stridor, he stopped feeding, wheezing, fever or low body temperature or severe malnutrition. Whenever these are associated, severe is called very severe pneumonia, is what you need to remember. So how do you manage very severe pneumonia? Always first referral antibiotic is ampicillin plus genta and refer urgently to hospital, and you need to change to intramuscular from oral because nothing he is taking orally, right? So cloxacillin plus gentamicin if there is no improvement after the first 48 hours is considered with the management of very severe pneumonia is what you need to understand. So the drug of choice for very severe pneumonia is a favorite question of the examiner. Chloramphenicol intramuscularly for first 48 hours and then oral chloramphenicol for a total of 10 days is the recommended drug of choice for very severe pneumonia is what you need to remember. Now, हम इस देश के वासी हैं जिस देश में टीबी बहती है, right? So without a question on TB, exam is not for 200 marks. Exam is only for 199 marks because 1 mark, sure shot TB. So country with the highest TB burden in the world, India. India is the manufacturing center for TB, like China is the manufacturing center for COVID. Then MAN2, if you do, every 2 out of 5 Indians, right now in the classroom, if 5 are there, 2 out of 5 will be MAN2 positive. I got 3 times TB. First, when I was in a small village while studying in school. Then when I was in MBBS first year while in anatomy, that time very severe attack of TB. Next is when there is a lot of stress when preparing for entrance exam, I had pleural effusion. Right? My classmate only, who was already doing first year PG, did a pleural effusion tap, TB found, took a antimicrobial treatment, of course. Next batch, I got that good rank. So TB is such a florid challenge. Incidence, prevalence, these are the various parameters. Incidence of TB infection is also called annual infection rate or annual risk of infection. It is the percentage of population under the study who are newly infected with TB among the non-infected in 1 year. New cases are always incidence. So percentage, and means into 100. New cases by non-infected cases over a span of 1 year will give you annual infection rate. So they came up with a national strategic plan 2017 to 25. The main idea is to achieve a TB-free India, like Indira Gandhi time, गरीबी हटाओ. गरीबी कहाँ हटाएंगे? क्योंकि गरीबी के लिए politicians are half contributory. So गरीबी हटाओ के जैसे आजकल TB हटाओ. So TB-free India, 5 years ahead of the global elimination plan. World is thinking of eliminating it by 2030 and India trying to eliminate it by 2025. And India is the largest country with TB. So, you should know what are the components of the National Strategic Plan of Honorable Prime Minister Modi ji. 12,000 crore rupees is allocated for next 3 years. Rupees 500 per patient for the nutritional support of all the TB affected patients under revised National Tuberculosis Program. Free of cost diagnosis and treatment facilities, including anti-TB drugs to all the TB patients under the revised NTC, National Tuberculosis Program. These are the components of the National Strategic Plan. Definitely one MCQ आएगा कल के NEETPG में, आप हमको याद करोगे. 2017 to 2025 is what you need to remember. So, tuberculosis annual infection rate. What is the importance of this parameter? It is the attacking force of the TB in the community in the developing countries. So tomorrow's MCQ will be, what is that particular index, epidemiological index, which expresses the attacking force of the TB? What is your answer? Annual infection rate, which is the incidence of new cases among the non-infected. 1% of the ARI corresponds to how many sputum positive cases out of 1 lakh general population? Once for this, a numeric, 50. 50 sputum positive cases in 1 lakh population is equal to, corresponds to 1% annual risk of infection. That's what you need to basically remember. So this annual risk of infection, which is also called tuberculin conversion index, it is the best indicator for the evaluation of the TB trend in the community, is what you need to remember. Now, what is meant by prevalence? Prevalence, obviously, new and old cases. Both of them will be tuberculin positive, tuberculin MAN2 test positive. So all people who are MAN2 positive, whether new and old, combined together is called prevalence. Whereas tuberculin conversion index means those who were earlier MAN2 negative now became MAN2 positive. That is annual incidence, right? So prevalence represents a cumulative index of both recent and remote infection of TB, as all of you know very well. So tuberculin test is the only way to estimate the prevalence of the TB in the population. Now, what is meant by incidence of disease? Disease is different from tuberculin positivity. Remember, annual infection rate means there it is not disease. It is tuberculin positivity that we are looking for. New cases who are earlier tuberculin negative became tuberculin positive now is called ARI. But incidence of the disease is percentage of new TB cases per 1,000 population will give you incidence. So what is the importance of incidence of TB disease? Incidence of TB disease. To know the trend of the problem, including impact of your control measures. Is RNTCP effective or not? How do you know? If the incidence of disease is altered, new cases of TB is altered. Now, incidence of disease, is it useful in every country? If you go to America, incidence of TB disease is not much relevant because TB itself is very low in America. In India, it is very high. So, incidence of disease is a good measure only in the countries where the TB is highly prevalent, is what you need to basically remember, right? Now, sputum smear examination. You have taken the sputum sample, sent it for microbiological examination. This is the best way to estimate incidence of the disease. That means you need to define, no? Incidence of disease means who is diseased. Simply man-2 positive is not diseased. Even a old case can be. Somebody who got exposed also may be man-2 positive. Disease hona hai to you have to prove that there is AFB in the sputum. That's the reason sputum smear examination for AFB is the reliable method of estimating the incidence of the disease, is what you need to basically remember. So all these things look very simple, but after coming out of exam hall, wow, you will be regretting. There is a man-2 test in the options, sputum smear for AFB in the options. You should tick mark sputum smear for AFB is the way measured to identify the incidence of the disease, is what you need to basically remember. Now, prevalence of the disease or the case rate, it is the percentage of the individuals whose sputum is positive for TB bacilli on the microscopic examination is case rate, actually. So one point you need to remember, if sputum is positive for AFB does not mean he's a new case, always. Even a old case, a case who is refractory to who has a multi-drug resistance, anyone can be sputum positive. That's the reason case rate is percentage of individuals whose sputum is positive for TB bacilli on microscopic examination also will give you prevalence of the disease or the case rate. So if you want to know the case load in the community, the best measure is prevalence of the disease is the best measure to know the case load. Now, if you want to estimate the case load, there is a better index than simply prevalence of entire population. What is a better index than the entire population prevalence? Age-specific prevalence of the TB. How many in the 15 to 24, 25 to 34, 35 to 44? That is a more relevant index to know the case load in the community, is what you need to basically remember. So what is prevalence of suspected cases? So suspected is not different from proven cases. It is all based upon the X-ray chest. But there is not much of epidemiological importance for prevalence of suspect cases. But you can use X-ray in order to calculate the prevalence of suspect cases, is what you need to understand. Then prevalence of drug-resistant cases. This is a parameter directly related to chemotherapy. Now, who discovered tuberculin test? Kaun banega PG Pati program? Who discovered tuberculin test? Von Pirquet in 1907. That means today we are in 2022. If the Swiggy delays by 5 minutes, we are disappointed. If our Instagram post or Facebook post don't get to more than 10 likes, we are depressed the whole day. Right? In the WhatsApp, if the people don't say LOL and clap for your jokes or forwarded posts, you are disappointed. Imagine if we are born in 1900s, how deprived we are. World War on one side, bombs on another side, TB on another side, pandemic on another side, economic depression on another side. Still, we all survived. So that means Swiggy is not needed to survive. Be very sure. So somebody was saying this cancer of coaching is needed to get rank. This cancer is introduced by you only, Dr. Murali, they are saying. Because way back in 1999, when I started coaching program, there was nobody. In entire South India, middle part of Central India, it was only Dr. Murali Bharadwaz. In North India, Dr. Badia used to be there. So after that, so many people came. So Von Pirquet also will be heaving in his graveyard if the NEETPG aspirants don't know that who discovered tuberculin, right? Huh. So tuberculins, how do you prepare? Not only from Mycobacteria, tuberculosis, even from Canaceae, Bati, Scrofulatium, these are all atypical mycobacteria. Even from them also tuberculins, which are used to do the tuberculin test, are being prepared. Now, what is a standard purified protein derivative of tuberculin? So it contains 50,000 tuberculin units. Otherwise, one tuberculin unit is equal to 0.402 milligrams of ppd, right? So this is a dirty numeric in the last 30 days program mein tick mark karo. So what is the strain used by the WHO? ppd rt23 between 80 is that strain of the mycobacteria which is used for preparing the tuberculin to do the MANTO test by the WHO is what you need to remember. And the ppd that you use in the MANTO is divided into first strength, intermediate strength, second strength. One tuberculin unit, if it contains first strength, 5 TU means intermediate, 250 TU means second strength. Don't worry. Some things we have to act as such we understood them, right? Because for ultimately, these are all some of the standard FAQs by the examiner. Tuberculin test conversion, how do you define? It is an increase of 10 mm or more within a 2-year period regardless of age is called tuberculin test conversion, is what you need to remember. MANTO's tuberculin is what type of test? Where will you inject it? Will you inject it IV or kill the patient intrathecally? How do you give? Intradermal test. You know, during Vibrio, we play with the students' life. How do you give MANTO test? Sir, MANTO test, sir. IM, sir. IM? Come on. Yes, sir, intrathecal, sir. Now I remembered, sir, intrathecal, he will say. Right? So, Vibrio is, today's examiners are very easygoing. Very easygoing. In our days, professor of SPM, professor of forensic, they used to be egotic pond. You know, when I went for PSM exam, Dr. Gowd was our professor of SPM. By the time I'm a very popular author, I wrote a 4,000 MCQs for Robbins pathology when I was in second year MBBS. That I already had about 40,000 subscribers, buyers of the book. And I already wrote for Park textbook a MCQ review, original MCQ review. So I went to exam hall. ఎన్ని రోజుల్లో తగ్గుతుంది నువ్వు కీమోథెరపీ ఇస్తే patient, when will he become non-infective, he asked. According to the PARC page number 448, within 48 hours, 96% of infectivity will come down. Communicability, I said. So you are a guru of PARC. All right, go, he said. No other questions. ENT distinction, ophthalmology top marks, SPM failed. SPM failed. Luckily, it doesn't stop you from moving forward, right? So next time, you understood how to fail, how it looks when you fail exam. So don't tell me page number this time. He said, now once more, I'll ask you a question. I thought, what question he will ask? Within how much time the patient become non-infective after you start chemotherapy? Sir, 48 hours. Now get out, you're past it. So those days, professors used to be unbearable. Today's professors are all diluted. It's like you add water into beer and drink. Utna diluted stuff, today's professors, right? So students are actually failing in theory and passing in Viva. So Mantoux tuberculin is a intradermal test, is what you need to remember. There is also another thing called Heath's tuberculin test. It's quick, easy, reliable, cheap, and preferred for testing large groups. Is Heath. That's what you can remember. Then tuberculin test is the only way, if you want to estimate the prevalence in the entire population, is what you need to remember. Now, tuberculin, is it a specific test or a sensitive test? You know what is sensitive, specific? Sensitive means when the disease is very early, it can pick up. Specific means it will only pick up the disease, not anything else. So, in all the countries where there is a high coverage of BCG in childhood vaccine, they're all tuberculin positive. That's the reason it lost its sensitivity as an indicator of prevalence. Anybody who do tuberculin test, he will turn out to be positive because everybody received BCG in their childhood. So, what is the reason that using tuberculin test, you can't really calculate the true tuberculin or true prevalence rate? Number one, there are a lot of atypical mycobacteria in our environment, right? They will also cause the tuberculin positivity. That's the reason the true prevalence rate calculated by the tuberculin test are actually exaggerated rates because of the atypical mycobacteria. Then second dose of tuberculin, boosting effect of the second dose of the tuberculin is the reason that prevalence rates are all exaggerated in countries like India where there's a high prevalence. If you use the tuberculin test, right? Now, MAN2, what is the dose that we use in MAN2 test? 1 TU of PPD in 0.1 ml injected intradermally on the forearm. PPD RT23 tween 80. You should sound like a parrot in the tomorrow's exam. MAN2 is only a prognostic test, but not a diagnostic test. So what does it mean? If somebody is MAN2 positive, it only tells whether that person's cell-mediated immunity is working or not working. It does not tell anything. Suppose if the person is immunocompromised, even if he has got TB, MAN2 will be negative. That's the reason it is only a prognostic significance, talking about how good is the cell-mediated immunity of the person. It has nothing to talk about diagnostic. You can't say, just because MAN2 is positive, this guy is definitely TB. No, you can't. It's not diagnostic. MAN2 lacks specificity. So already MAN2 lacks sensitivity because we are a country where everybody is received BCG. So sensitivity is not there. Even specificity is not there because there are so many atypical mycobacteria which also can cause MAN2 positivity. So it has no specificity also. But still we use MAN2. Still we ask MCQs on MAN2, right? Because that is what we regularly do. So MAN2's readings are read after 72 hours, 3 days. And what you measure whenever we say 5 mm, 10 mm, 15 mm, 20 mm, 25 mm, it is the induration which is measured. Induration which is measured. So how do you value the MAN2 test readings? Induration more than 9 mm is considered to be positive. 6 to 9 mm, doubtful. Less than 6 mm, negative. This is the sure short MCQ in the tomorrow's NEETPG. So if it is positive, it means either there is a past infection or a current infection with TB. If it is 6 to 9 mm, doubtful, that means Mycobacterium tuberculosis or atypical mycobacteria, which is it? We don't know, is responsible. Less than 6 mm is then considered to be negative, is what you need to remember. Now comes favorite MCQ of examiner. What leads to a false positive MAN2? What leads to false negative MAN2? False positive means there is no TB but MAN2 is positive. False negative means there is TB but MAN2 is negative. Right? False positive means there is no TB but MAN2 is positive. When will that happen? No TB, but because of the faulty injection technique, degraded TB, tuberculin, if you use too deep injection, other mycobacterial infections, repeated tuberculin testing, PHC doctor tested it, district doctor tested it. Finally, you came to pulmonologist in the city. He too did a MAN2 because patient don't know to tell. And doctor forgotten to ask. There's a whole misery of clinical medicine. Right? Taking drug history, taking menstrual history, feeling the pulses, checking the blood pressure. These are all the things that should happen involuntarily. Drug history, menstrual history, compulsory. Otherwise, lot of calamities can be prevented. If you make it a habit from day one when you are talking to patient to take all these histories involuntarily, right? So, repeat and prior BCG vaccine, they all cause false positive MAN2. False negative MAN2, that means there is TB but MAN2 is negative, is false negative MAN2. So where do you find false negative MAN2? If he is in a pre-allergic phase, high fever, measles, chickenpox, whooping cough, malnutrition, HIV, AIDS, any anti-allergic drugs, immunosuppressants, anything that is attenuating his cell-mediated immunity will lead to false negative MAN2 is what you need to remember. Now, how do you read the Tuberculin test? One point you need to know about Tuberculin test. More than 9 is generally considered to be positive. Less than 6 is negative. But there are a subset of population in whom even 5 millimeter is considered to be positive. Who are they? One of the favorite questions. If the person is HIV positive, even 5 mm is considered to be positive. Recent contact of TB case, 5 mm also is positive. Person who has got chest X-ray which is showing nodular and fibrotic changes, suggestive of the old TB, even 5 mm is positive. Patient on organ transplant, patients who are immunosuppressed, even 5 mm is considered to be positive, is what you need to remember. Then, in which subset of people 10 mm or more is positive? Is the question. Just one second. So when do you consider the tuberculin results, even 10 mm or more as positive? Those who have recently arrived, less than those who have recently arrived, less than 5 years ago, from a high prevalence country. Similarly, the injection drug abusers, even for them, the results of tuberculin are considered to be positive. If there are 10 in them, 10 or more are positive. Residents and employees of the high-risk congregate settings like prisons, nursing homes, etc. Mycobacterial lab personnel, for them 5 mm, 6 mm is not considered to be positive. Person with clinical conditions that put them at high risk, and children less than 4 years of age, or the children exposed to the adults who are high risk category, they are considered, for them 10 mm or more is considered to be positive. So if there are no risk factors at all for the TB, right? You brought a healthy athletic individual. In them, 15 mm or more is positive if there are no risk factors at all. So 3 points you need to remember here. One is, for whom 5 mm is considered to be positive, for whom more than 10 is considered to be positive, and for whom more than 15 is considered to be positive is the favorite question of the examiner. So if I ask you, what is the method of choice case finding tool for TB? Gill Nielsen staining by direct microscopy. So tomorrow this, how to identify mycobacteria on a histology slide will be one of the favorite image-based MCQ in the exam. Similarly, examiner will show you a banana in the complete blood picture, peripheral smear. You should identify falciparum malaria, right? So there are at least 500 to 600 classical images that will come in NEETPG exam. We will once run a session on all the 600 images. At least there will be 10 to 15 questions on image based. And always remember, image based are easier questions than the regular questions. Toughest questions are facts. What is the length of external artery canal? You have to take out a matchstick and try in the exam hall, right? Either in your ear or in your surrounding aspirant's ear, right? So that's the reason, be very sure on the numerics. Then, where is the sputum examination facilities are provided in India? District chest clinics, regional chest clinic laboratories, there all samples will come there and there they will do the processing. Because the local technician will not be competent enough to do the examination. So if the patient is smear negative, right? When is sputum for TB, sputum culture is indicated for diagnosing TB. Just symptomatic and smear is negative. You thought that it is TB, but smear is negative. Such people's sputum culture is being done is what you need to remember. All right. Now, sputum culture is also done for monitoring drug treatment. And if you want to know the drug sensitivity, you will be doing sputum culture is what you should remember, right? So, you are in any pressure of leaving, doctor? No? Sure. Because 100 students are there, one can leave easily. Only 2 of you are there, then if something urgent comes, please let me know. So next, mass miniature radiography. What is the importance? Nowadays, it is not used as a case finding tool, but once upon a time, they used to use it. Suppose you have a pulmonary TB and none of the sputum samples are positive for mycobacterium, but you are clinically suspecting. Similarly, if there is any suspected bronchiectasis, aspergilloma-like complication in the positive sputum cases. Similarly, sometimes TB patients can develop pneumothorax, pericardial effusion, pleural effusion Only in that place, mass miniature radiography has a role. But otherwise, mass miniature radiography is no more used as a case finding tool, but for identifying complications, etc., etc. That is all the story. There are some statistical values of TB, most recent values, 15, 20 points. I will give it in the next class, right? Because I need to buy the new park in order to identify those values. Now, polio virus serotypes, 1, 2, 3. Next, let's talk about polio. 3 favorite MCQs are examiner, you should know. Most common cause of the polio epidemics is serotype 1. Most antigenic and easily eradicable, P2. And which is most commonly associated with vaccine-associated paralytic polio, P3. That's what you need to remember. So in the life cycle of polio, who is the reservoir? Man is the reservoir. And there are no chronic carriers. Is symptomatic clinical paralytic polio common or subclinical cases common in polio? Most common type of clinical presentation of polio in the community is subclinical cases. For every 1 clinical case, there are 1,000 subclinical cases in children and 75 subclinical cases in adults. This is what the numeric you need to remember. Now, what is the infectious material for polio? Feces, oropharyngeal secretions, they are the infectious material. And what is the period of communicability, doctor? 7 to 10 days before and after the onset of ek hafta idhar, ek hafta udhar, from the day of diagnosis. Now, what are the risk factors that precipitate polio attack? Any fatigue, trauma, IM injections, operative procedures, especially tonsillectomy. In the epidemic of polio, never do tonsillectomy. And alum in the DPT vaccine also is a precipitating factor for the polio attack, is what you have to be very, very sure about. 3 to 35 days is the incubation period, usually 7 to 14 days for the polio. Now, what is the clinical spectrum of polio? Subclinical, inapparent cases, no presenting symptoms. 95% of times, they are all inapparent. How do you identify them? You have to discover rising antibody titers. Today, one sample, 48 hours later, another sample, and rising antibody titers is the only way you can catch a subclinical case. Abortive polio, that means minor illness, like abortive Omicron. A lot of people got Jalubu, Sardi, but Omicron came and gone. So mild or self-limiting illness and recognizable by isolating rising antibody, even abortive polio. Abortive polio constitutes 48%. Non-paralytic polio presents as aseptic meningitis, viral meningitis, 1% of cases. And paralytic polio is descending, asymmetric, flaccid paralysis. Unlike Guillain-Barré, which is ascending, symmetrical, acute flaccid paralysis. Whereas polio is descending, asymmetrical, acute flaccid paralysis. And paralytic polio is less than 1%. But less than 1% is also very severe. Now, what is the best method for laboratory confirmation that this acute flaccid paralysis is due to polio? You have to do the isolation of the wild polio virus from the stool. Is a recommended method for laboratory confirmation. So stool examination is recommended in every case of AFP. Any acute, what are the common causes for acute flaccid paralysis? Transverse myelitis. It is a viral infection infecting the entire spinal cord. So in the spinal cord, you have Androhon cells, which are motor. So once they get affected in transverse myelitis, that lead to AFP. Guillain-Barré syndrome is AFP. Polio is AFP. So stool examination is recommended irrespective of what is underlying cause in every case of AFP in the community is what you need to remember. Now, when will you find virus? Virus is found in the feces up to 8 weeks after paralysis. And the highest probability of detection is in the first 2 weeks after the onset of paralysis. Do you want to do CSF examination because it can lead to aseptic meningitis, no? Polio. It is not recommended for surveillance, not recommended. Because in the CSF, you don't get any virus. Stool only, you will discover the virus. That's the reason for surveillance, CSF is not recommended, is what you need to remember. Then, CSF ka cell count, gram stain, so that bacterial causes of meningitis can be ruled out. Protein glucose. If it is bacterial meningitis, glucose levels will fall down in CSF. Whereas viral meningitis, normal CSF glucose levels. So, protein and glucose eliminates the other causes of AFP from polio. So, what do you get in Guillain-Barré syndrome in CSF? Even Guillain-Barré syndrome lead to acute flaccid paralysis. It lead to albuminocytologic dissociation. What is the meaning of albuminocytologic dissociation? Typically, there is an increase of albumin, but whenever there is a bacterial meningitis, albumin increases, pleocytosis will also be there. Whereas in this, albumin and the cell count rise are not proportionate. That's called albuminocytologic dissociation of GBS. So to know whether it is GBS or whether it is polio, CSF will help. That's the only purpose, not for isolating the virus. That is a short story of polio. Next comes hepatitis virus in Park textbook. Once more, where do you read hepatitis? Anantanarayanan Microbiology, Park, Pediatrics, then gynops, pregnant and hepatitis. How do you manage? General medicine. Right? So there are Panchabhutam for some topics. That means entrance is not for 200 marks. It is for 198 only. One definite TB, one definite hepatitis. Like that, if you count, doctor, out of 200, 160 topics are predictable, are absolutely predictable, right? So just like in the class, we used to check to which girl we propose, we get slapped. To which girl we propose, she will tie Rakhi. To which girl we propose, she will start loudly shouting. That's called predictability of the outcome, right? So there's no surprise. So similarly, examiner also no surprise. Oh, where is my TB question? Where is my polio question? Where is my hepatitis question? Like that, you should look in the exam hall. All right. So the secret is, once more, I'm telling you, 60,000 points revision with Dr. Murali Bharadwaz, 600 hours of your beautiful life sacrificed. Right? Another 200 hours to do the revision. Right? And last 30 days. So totally, if you are able to give 600 plus 200 for revision and another 200 hours during the last 30 days, 1000 hours आप दे दो, 1000 के अंदर रैंक मिलेगा, right? Shanti. And don't read, your total reading or preparation time in a day should not exceed more than 6 hours. Understand? More than 6 hours. If you don't exceed, because if you say I'm reading 10 hours, 12 hours means I'll be sad. If you can read 10 to 12 hours, you don't need coaching. Why do you need coaching? You should read less, enjoy the life more. Morning, nicely sleep, be happy. Teacher will do the reading job, come with you, precise points, what you need to revise, I will tell you. Right? So that for the fee you have paid, there should be justification, value for money. Right? Otherwise, 10 to 12 hours, somebody demanding you to read means he's not a coaching guru. He's a ghost. Right? I'm not ghost. I'm an angel who came from the planet heaven to the earth to help to be your messiah, savior, to make you to read less and then get better rank. So, doctor, hepatitis A. Please remember one of the favorite questions. Each hepatitis, which class it belongs to? Hepatitis A is enterovirus 72 picorna virus. Hepatitis B is hepadna virus. Hepatitis C is flavivirus. Then hepatitis E, calcivirus, which is also called alpha virus-like. Common question in the exam. Once more, it is cruel to remember which is picorna, which is hepadna, which is flavi, which is alpha. You need to be very sure. This is the dirtiest question. Incubation period of each of the hepatitis. 15 to 45 days is hepatitis. 30 to 180 days is hepatitis B. 15 to 160 is hepatitis C. D is 30 to 180 days and E is 15 to 60 days. Last 30 days revision में डाल दो. Now, what is the common mode of transmission? Hepatitis A is feco-oral and sexual is anal sex can cause hepatitis A. Hepatitis B, sexual, perinatal, percutaneous. Hepatitis C, only percutaneous. Hepatitis D, sexual, perinatal, percutaneous. And hepatitis E, feco-oral. That's what you need to remember. Now, 5-6 points about each of them. Hepatitis A, 2 week ke pehla, 2 weeks before, 1 week after the onset of the jaundice is the period of infectivity. It is common in both sexes equally. Children are more infected, but in children, hepatitis A is more milder and subclinical. Just like COVID. Human cases are the reservoir. And formalin, ultraviolet rays, boiling for 5 minutes, autoclaving, they're all the methods of disinfection of hepatitis A is what you need to remember. Hepatitis B is also called serum hepatitis is what you need to remember. So how do you describe hepatitis B? It is a double-shelled DNA virus, dense particle. Basically, the DNA core is called dense particle. And man, either a case or a carrier, either of them is a reservoir of hepatitis B. Median incubation period is less than 100 days. Then comes the real hot question. If you understand this, if you remember this, you are pocketing 1 mark in entrance exam. Right? So, markers of hepatitis B. So, there are antigens, antibodies. Antigen is a daughter-in-law. Antibody is a mother-in-law. When when the mother-in-law comes, daughter-in-law disappears. Because they both can't exist in the same kitchen. Right? So, when antibody comes, antigen vanishes from the serum. So you have a surface antigen, you have a core antigen, you have an envelope antigen. Barabar? Then you have a core antibody, you have a one minute. Sometimes if I hit this pad sensitive. So core antibody, envelope antibody, surface antibody. Now comes, remember the order of their appearance. First surface antigen, then core antigen. But core antigen is not found in serum. Envelope antigen. Then comes core antibody, not surface antibody. Then envelope antibody. Then surface antibody. Now tell me the order once more. Surface antigen, core antigen, envelope antigen, core antibody, envelope antibody, lastly surface antibody. Please don't forget this order, doctor. Okay? Now, 2-3 comments about each of them. Surface antigen is also called Australia antigen. Why they call it, I don't know. But they call Australia antigen. First antigen to appear in serum, first evidence of infection. Examiner will ask you tomorrow's exam. That is surface antigen. Epidemiological marker for hepatitis B infection. You want to go to community and find all hepatitis B positive people. Surface antigen will help you. Core antigen. It does not appear in serum, hence called core. Then envelope antigen. Envelope antigen is the secretory form of the core antigen. Core antigen has a secretory form which appears. Core antigen doesn't appear. So envelope antigen appeared means there is an active viral replication. It's a marker of replication. If it is replicating, patient is also infective. So it is also a marker of infectivity for hepatitis B is what you need to remember. And if the envelope antigen persists beyond 3 months, then there is a likelihood of chronic hepatitis B. That means if envelope antigen is there, daughter-in-law, mother-in-law, antibody should be produced. Envelope antigen is supposed to disappear. But if the envelope antigen is persisting beyond 3 months, then the likelihood of chronic hepatitis B is very high. That's what you need to remember. Then comes anti-core antibody. Antibody to hepatitis B core antigen. It is the first antibody to appear in serum. First is core antibody, then envelope antibody, lastly surface antibody. In that, there are 2 types, IgM type, IgG type. IgM indicates acute hepatitis B. IgG indicates chronic, and it will persist indefinitely, forever. Ek bar hepatitis B aa gaya to hepatitis B core antibody, IgG type, will be persisting indefinitely. Right? So IgG anti-HBC will be persisting indefinitely. Once more, this is an image-based MCQ. Examiner will tomorrow ask you what are these individual parameters. You have to be very sure. Anti-hepatitis B envelope antigen, anti-HBE antibody. If it appeared means antigen will be gone. Envelope antigen is gone. If antigen is not there, viral replication stopped. So it signals end of the active viral replication, end of the period of infectivity. Somebody who is having hepatitis B envelope antigens antibody is no more infective. That's what you need to remember. Then surface antibody is the last antibody to appear in the serum. It means recovery, end of the period of communicability, etc. etc. Now some combinations. Serum may, these are the values, and what is your diagnosis? Examiner will ask you tomorrow. A patient is having antigen positive, surface antibody negative, core and antibodies of IgM type, envelope antigen is positive, and anti-HB is negative. What is your diagnosis? Surface antigen positive, IgM type, envelope antigen is positive. That means it is acute hepatitis B where virus is replicating, is what you need to remember. Then somebody is surface antigen positive, surface antibody negative, but the core antibody is of IgG type, and envelope antigen negative. Envelope antibody appeared. Obviously, when it appeared, if mother-in-law appeared, daughter-in-law disappeared. Antigen negative. What is this? He is a chronic hepatitis B because IgG is positive, right? Positive. And because anti-HB is positive, replication stopped. He is not replicating the virus. Then surface antigen is negative. Surface antibody appeared. Core antibody indefinitely will be there anyway. Envelope antigen negative, envelope antibody positive. Means he recovered because surface antibody appeared. All right. Then if you are vaccinated in your internship for hepatitis B, what will you show? You will have surface antigen negative. If your surface antigen positive means you are infected, acute. Anti-HB is positive. But it is not a natural infection, vaccine. That's the reason core antibody will be negative. Envelope antigen will be negative and envelope antibody will also be negative. Only anti-HBs will be positive. And just because you vaccinate in your internship, don't think you are okay even when you become consultant. Over a period of time, your hepatitis B antibody levels will, vaccine-associated antibody levels are there, no? They will come down. So that's the reason you need to get a periodic assessment. That's what you need to remember. So what are the various vaccines for the hepatitis B is a very, very important question by the examiner. Plasma-derived vaccine. Then based on hepatitis B surface antigen, formalin inactivated subunit vaccine, and those derived from the carriers of hepatitis B. Then recombinant DNA yeast-derived vaccine, recombinant DNA vaccine which is genetically engineered. These are the various vaccines available for hepatitis B. Now, there is also a hepatitis B immunoglobulin. So what is immunoglobulin? I already told you. Passive immunity or active immunity? Immunoglobulin. Will it give an immunological memory? Very good. Passive. Live and killed will give active because they create immunological memory. Immunoglobulins, maternally transported antibodies, they all give passive immunity. So hepatitis B immunoglobulin, why do you give? For immediate protection. Passive immunity. For example, a surgeon, nurse, laboratory worker, newborn infant of a carrier mother. Suppose a surgeon, right? So I got 2 times HIV needle prick. One time while doing dialysis of a patient, the blood spattered into the eye. Hepatitis C. In fact, that patient was double positive, both B and C. B is okay because immune. C, no vaccine also. So 2 times I had to take 1 month retroviral therapy for HIV because the needle prick, right? When I was doing post-graduation in 2002, very rampant. Even today in rural area segment, HIV is there, right? But in those days, we used to see a lot more. So, and being a doctorate, we are more threatened because too much knowledge is there, no? So my chief said, Murali, if you take nevirapine, what do you get? Tell me. Steven Johnson. Are you ready for that? If you take efavirenz, you'll get suicidal depression. Are you ready for that? Then if you take protease inhibitors, you will get lipodystrophy. Suddenly a big lump will come on your nape. Which one do you want, Murali? He asked. Said, I love to die rather than all these complications. I thought Steven Johnson is very bad. All skin will be gone. Sir, Efavirenz is okay, sir, for me. Because suicidal depression means all right. I can live with that. Anyway, we are all living with that. So, said all right. So, Efavirenz was started. But I did all 30 days. I stayed in emergency medicine department in NIMS doing night duties, right? So suddenly I used to sweat in the middle of a short nap also. Efavirenz truly causes that suicidal depression, right? So, and nightmares. So very risky situation. So hopefully when you do PG, when any needle stick injury is there, first don't panic. First, don't panic. Second, don't evaluate quickly, immediately. Immediately, nobody will be positive. Third, don't go into a thought that what will happen tomorrow, cryptosporidium in my brain, pneumocystis carinea, pneumonia in my lungs. Stop thinking. Most important, don't go to Google. Call me, I will tell you, nothing will happen, right? After that, at least 30. Recently also, one Usmania Medical College girl, one of our students, she had a needle prick injury. But absolutely all right. So, what is the dose of hepatitis B immunoglobulin? 0.05 to 0.07 ml per kg, 2 doses, 30 days apart. Then comes HEV. HEV is a waterborne disease, doctor. So water and food supplies contaminated by feces transmit hepatitis E. Hence, hepatitis E is called enterically transmitted non-A, non-B hepatitis is the name given for it. And 2 to 9 weeks is incubation period. Then why you need to remember HEV? HEV is the most common cause of the fulminant hepatitis. One case of fulminant hepatitis, if you see, you won't forget in life. Patient will get florid jaundice, go into hepatic encephalopathy. You can't do anything. Patient stormed to death. Such a very fast clinical regression. Fulminant hepatic failure. It is in pregnant women most commonly due to HEV. Now here there is a tricky question. If the examiner asks you only most common cause of the fulminant hepatic failure is which hepatitis virus? Answer is HBV. Hepatitis B. But most common cause of fulminant hepatic failure in pregnant women, HEV, is what you need to remember. Almost 80% case fatality rate. That is the story of the hepatitis. So lastly, before we conclude today's journey, quickly let us run through a dirty topic called oral rehydration. Risomol. What is risomol? Rehydration solution for malnourished is called risomol. So WHO risomol packet, 2 liters water, 50 grams sugar, 40 grams electrolyte and mineral solution. Now, what is the composition of ORS? One of the favorite questions. Sodium 45, potassium 40, chloride 70, citrate 7, glucose 125, and all other 4, total is 300. To add to the pain of our remembrance for NEETPG, there is something else you need to remember. There is a new recommended reduced osmolarity oral rehydration. Right? And one more thing. One is you have to remember in terms of millimoles per liter. Other you have to remember in milligrams also. Appa, life is a shit pot. Right? We have to survive. NEETPG means for everybody this is painful. But still we need to develop some method. So sodium chloride 2.6 grams. Potassium 1.5 gram, Sodium citrate 2.9 grams, 13.5 is a glucose, total is 20.5 gram packet. Is your ORS, new WHO recommended low sodium ORS, it is called as. The same low sodium ORS, you should remember in millimoles per liter. This is what? Milligrams. You need to translate that into millimoles. But, it's worth remembering, because in this country where dehydration is very common, your patient will come with better knowledge than you about ORS composition means bad, no? MBBS पढ़ने के बाद मुझे ORS में क्या है मालूम नहीं, मेरे पेशेंट को गूगल बोल रहा है कि क्या है. So that is very bad. So you have to mug this. Sodium 75, potassium 20, chloride 65, citrate 10, glucose 75, total 245 millimoles per liter is the low sodium ORS new recommended formula, is what you need to remember. Let us quickly finish cholera also. What is Vibrio cholera? Gram-negative bacterium. And why does it lead to diarrhea? Because the Vibrio cholera toxin acts on the GM1 ganglioside. It has got a subunit which binds with the G protein, and that causes adenylate cyclase, which causes cyclic AMP formation. Cyclic AMP in turn will cause the chloride to diffuse. That will pull sodium and water out. That lead to the secretory diarrhea that you see with Vibrio cholera. So, A subunit, G protein, adenylate cyclase, cyclic AMP, and chloride channel. You need to remember buzzwords for Vibrio cholera. So, Vibrio cholera has got a O1, O139, O2, O38, 138, and O142, O2, O6. O1, O139, you remember. O139 is called Bengal strain. O1 is classical and L-tor. In that you have L-tor mein Ogawa, Inaba, Hiko, Jima. The three strains. So mainly classical and L-tor by time. Once more, all these things will revise in microbiology also. So Vibrio cholera's L-tor biotype. In that, Ogawa is most common in India. You have Ogawa, Inaba, Hikojima in the L-tor. In that, Ogawa is most common in India. So, next March, when you are a dermatology resident or a cardiology resident, you will be laughing. That Ogawa, Inaba, Hikojimas, all mantras, they were like Betal. We are preparing for entrance last summer. We will think about. But that's a good memory. Recently in India, L-tor hybrid subtype has become most common in India. Now, cholera has a 1 to 2 days incubation. Human beings, only human beings are the reservoir. What is the diarrhea called? Rice watery diarrhea. And what is the most key element in treatment? Not antibiotics. Water electrolyte replacement. ORS is the key, is what you need to remember. So how do you do the laboratory diagnosis of cholera? Stool and swab samples collected in the acute stage before you have given antibiotics are the best specimens. Now, what is the holding or transport medium? How do you send that stool sample? Venkataraman Ramakrishnan medium, which is called VR medium. But most popular is Carey, Blair medium, most widely used, and autoclaved seawater. They are the holding or transport media. Enrichment media. Enrichment will promote the growth. Alkaline peptone water. Monsoor staurocolate tellurite peptone water. These two are enrichment media for Vibrio cholera. Then plating media for cholera. DSA, alkaline bile salt agar, Mansour's gelatin tarocolate, trypticase, tellurite, GTTA medium. But most important thing, most popular unit, remember, is TCBS medium. TCBS. Yeah. So that's what you need to remember. Now, most important thing in any epidemic is what? Verification of diagnosis. First step. Verification of diagnosis is the most important part of evaluation of a epidemic. To verify the diagnosis, just few patients' stool, if you collect, is enough. You don't need to collect all cases and all contacts. If you look at COVID, all contacts are also evaluated. Then if you take polio, all cases are being evaluated. But that is not the case with cholera. Just few patients is sufficient. Then cholera is notifiable disease. Locally, nationally, internationally, cholera is notifiable. Under international health regulation, cholera is notifiable to the World Health Organization within 24 hours. Right? Number of cases and deaths to be reported. And when do you call an area cholera free? Twice the incubation period has elapsed since the last case. You call it as free. Now, when do you want to give antibiotics? Only when vomiting stops as an adjunct. But main treatment is all what? Water and electrolytes. So what is cholera treatment? This is the favorite MCQ of examiner. Adults, doxycycline. Children, azithromycin. Pregnant, azithromycin. Chemoprophylaxis, tetracycline. Prophylaxis. After COVID in 2 years, who doesn't know these medicines? Even a village में grandma also. बुखार आ गया क्या? डॉक्सी ले लो, एजिथ्राल ले लो. So there is nothing that we need to actually treat in the modern day of. There was a time when a village granny is even asking, "Oh, Dexa le lo, Dexa." So that has become such a worldwide popular thing. So mass chemoprophylaxis do you want to give? It is not advised to the total community. To whom you want to give chemoprophylaxis? If there is one cholera case in the home, the household contacts or that closed community need to be given. All people in that apartment is okay. So to prevent one case of cholera, 10,000 people need to be given chemoprophylaxis. That is the rule. Right? And what is most effective prophylactic measure? You want to avoid cholera? Health education. भैया careful रहना, feces और food को add नहीं करना, hand wash करना. That is the most important thing. So that is all the story of cholera. Our Mr. Suresh also is very hurrying for going home. So we will conclude the class today. Otherwise, I prepared for another 1 hour. So, but he is so impatient that he may lock me down and walk out if I continue, right? So thank you so much for coming, doctor. And every day we will study. Most important, how many hours we read is not important, right? The same content of almost 100 points we discuss. For you to study yourself and write notes and all that, you would have taken 2-3 days. We saved all that time. Only your job is to revise at least that points that you forget, right? Enjoy the preparation. Thank you.